But Dr. Lisa McMahon is one of our surgeons who specializes in advanced laparoscopy, pectus excavatum, slipping rib syndrome, inflammatory bowel disease, and Hirschsprung's disease. She's the director of our chest wall clinic and surgical director of the IBD clinic. She holds many positions in local, national, and international committees. She's on the executive board for the Chest Wall International Group, is a co-chair of the Medical Advisory Committee and for the Crohn's and Colitis Foundation of America Southwest Chapter. She's part of the Pediatric Advisory Committee for the National Crohn's and Colitis Foundation, and also a member of the Physicians Leadership Group for Improved Care Now. She currently serves as our department chair of the Surgical Committee and the medical staff of Phoenix Children's. She's the director of the Advanced Pectus course, as well as a Fellows Pectus course. She holds certification from the American Board of Surgery and Pediatric Surgery, as well as general surgery. And outside the hospital, she enjoys hiking, travel, playing pickleball, and spending time with her family. So Dr. McMahon, thank you.
Thank you so much.
Okay,
Great.
That's advanced.
Okay, I love it. I love it. Thank you very much. Not according to my son. When he was 4 years old and I asked him what he wanted to be when he grew up, he said, maybe fireman, policeman. He's 17 now. Baseball player. And I was like, okay, well, how about surgeon? No, mommy, surgery's for girls. So in his experience, it's all about women and not about men at all. So we're going to talk about Pectus. I am a consultant for education with AtriCure, which is the company that does the cryoprobe. So Dr. Dixon set me up really well, so thank you very much for that. But we're going to talk about what Pectus is and kind of go through what we do for it. But it's a deformity of the chest wall, and it's actually a deformity of the cartilages. So the cartilages grow inward and push the sternum down. Sometimes the sternum's angled from one side or the other, and kind of at the beginning, it almost seems like with the kids that have a symmetric pectus, it's not angled at first when they're younger, and then as they age, one side moves to the other. It can be congenital or acquired, so sometimes can happen after chest surgery, but oftentimes it's mostly congenital. Here we go. Oops. Do I have one already? No, I have one more. Backward, forward. Really? Okay. There's a quiz. Did I just join it? Yeah, no, just press one. Oh, okay. Here we go. Yeah. Okay. The prevalence of Pectus excavatum is 5 times higher in males than females. True or false? Do I have to push again? Sorry, I didn't expect it. This should be pretty easy, right? How am I supposed to know? Here we go. I got it. Thank you. All right, here we go. So interestingly, this is not true. And so this is a little bit of a quiz, like a pre-quiz as opposed to a post-quiz. But all the textbooks will tell you that it's more common in men than females, men than women. But like Dr. Dixon said, it's actually very prevalent in girls too. We just don't see it as much. They don't come to our attention because it's harder to see. So originally the thought was it's 1 in 150 to 1 in 1,000 people. The male to female ratio was 5 to 10. We don't see girls' cleavage as much unless Paula Abdul wants to show it to us and show us her pectus. The guy on the top, he died, I think. I don't think he's alive anymore. He has a pectus. A lot of actors have pectuses. They do overbuilding of their chest walls to either emphasize their cleavage or try to hide it. And then this guy, I think his name is Pauly D at the bottom, actually has a different kind of pectus deformity. It's called an arcuatum, which is, we're not going to talk about it here, but it's a very, very rare one, but definitely accentuates what his pecs look like. So mostly the kids don't look like that. But the real prevalence, actually, we found out through the Dallas Heart Study in adults. And they looked at a lot of patients' CT scans, mainly for their hearts, but then we pulled out a subsection of those patients to look at their actual chest walls. And since we had this great group of people, men and women, we had multiracial adult prevalence, we found that actually it's way more common in females than in males. 1 in 200 in female adults and 1 in 333 in males. Now this is a Haller index of 3.25, so that the Haller index is calculated by dividing the depth over the width, and if it's greater than, a normal person would be about 2 to 2.25. Somebody who has a depression in their chest that's significant is over 3.25. Correction index we'll look at too, and that's kind of the change in the height of the chest wall. If it's greater than 10% here, it is thought to be a pectus, and we'll show pictures of that to see. So completely changed the way I thought about this. I'm a female surgeon, obviously. I tend to get more girls in my practice than my male counterparts. And I thought, oh, this is the girls who come to me either are found very, very young or have been seen by somebody else for scoliosis or something, and they get studies and they're like, oh my gosh, look at this pectus that we didn't know about. So it's a lot more difficult to diagnose in a girl than a boy because of breast development and modesty, I think. But we need to know about it. And it's one of those other social determinants of health that kind of drives me a little bit crazy, that girls don't get treated and looked at as much. So symptoms, we talked about this a little bit too. Shortness of breath with exercise sooner than expected. These are things that we see mostly. This is the main complaint. Exertional asthma, wheezing, sometimes we see that. Chest pain, frequent pneumonias, tachycardia, orthostatic hypotension. Somebody asked a question about why you get chest pain with this. I don't know if it's actually pain in and of itself or that feeling that you get when you run and you just can't run anymore. It hurts, right? It just doesn't feel great. It's not necessarily when they're at rest that it hurts. And I'll test them for costochondritis, just palpating along the costochondral border to see if they have pain in that area. And that's sometimes just what it is in the end. But they can also get a lot of cardiac symptoms from this. There are also psychosocial and cosmetic concerns, more for the boys than the girls, because the girls can hide it. Nobody's looking at their chest all the time. They don't have to take their shirts off to swim like the boys do, or to play basketball, those kinds of things. But the boys definitely get teased about it. What's our workup? So this is a pretty severe pectus. Obviously, spines at the bottom. There's a weird circle there. I don't know even what that is now that I'm looking at it, but sternum is at the top, probably a cartilage. So we get an MRI. You can get an MRI or a CT scan, but we tend to do an MRI to look at 3D imaging, no radiation, and we have a quick protocol, so it's not a forever scan. It takes about 10 to 15 minutes. Some people will get a cardiac MRI. In Arizona, insurance bars us from getting a cardiac MRI unless there's either a cardiac pathology that's already known or if we have known Marfan syndrome. I don't know, do you have a different experience with ordering a cardiac MRI? I can't seem to get one for a pectus, so it's really hard. And it's a longer procedure, and it takes a cardiologist to read it, and we don't get the results back for a month, so it's just kind of more cumbersome. But you do get beautiful images. We do a CPET, so we want to know how they're doing functionally. So you can have a pectus and it doesn't affect you if your heart shifted all the way over to the left and you don't even really notice it. But most of the time your heart doesn't shift and it's in the middle and it's getting compressed. The CPET is just an exercise test. They get on an exercise bike and they go for as long and as hard as they can to get a VO2 max number. And so what we've seen in kids with pectus that are severe is that they can reach their VO2 max and then it falls off, and they have low stroke volume response. So if you can imagine, that heart just can't beat very normally if it's in this position, and it can't get out the blood, the oxygenated blood, to the rest of the body well. And these kids just fatigue faster, and that's why they get these symptoms. We also order an echo. These are kids. We want to see if they have any congenital problems, but really we're getting it to rule out Marfan's. We're ruling out that aortic root dilation. The MRI doesn't always show this to us because the one we get again is kind of a more truncated one looking at the chest wall. Some people get PFTs. Sometimes that's part of the CPET, especially if they're having trouble breathing and getting through. Sometimes they'll get some albuterol while they're doing the treatment, and they'll get their PFTs too. And then allergy testing, plus or minus, I won't get into that so much here, but we do use metal bars. We have two different kinds. They're either made out of surgical stainless steel or titanium. So if you're allergic to nickel chromium or have a family history of that, then you get the titanium bars. There's a tiny, tiny percentage of the population that's allergic to titanium, and I worry as we go on and use more titanium, we're gonna end up with more titanium allergies. So far, so good though. All right, so originally people thought, oh, pectus, it's just cosmetic. We don't have to worry about this. So over the last 10, 15 years, we as a group of pectus surgeons and people that are involved in this have really done a good job of really looking at what are the physiologic implications. And this is a paper actually done in Cincinnati, but by our pediatric surgery fellow who just graduated last year. And it shows that they have this great group of people. We know that pectus excavatum is associated with cardiopulmonary dysfunction. And that if you look over here on the right-hand side, your Haller index and your correction index, remember the measurements of the chest, as the Haller index goes up, so as your numbers get worse, as the depression gets worse, they have worse cardiac and pulmonary function. As your correction index goes up, so again, more depression, they have less exercise capacity. We know, and interestingly, so girls have more pectus than boys. Girls' pectus is usually more severe than boys. Girls can overcome it a little bit better than boys, though. They actually have slightly better function, even though they have worse pectuses. And we see this both in the kids and the adults in studies that we've done with this. So it's kind of cool. In this study, too, they were able to do, in Cincinnati, they can do cardiac MRIs. They get them on everybody. So just a difference in terms of where you live and how things are done. But they see a lot of abnormalities, too. So here's a picture of a cardiac MRI. And the thing that I like about this is that it shows that your ventricle, that right ventricle, is not open because this bone here on the left side, is there a pointer that I'm missing? Yeah. This bone here. You can use a mouse, is better. Mouse is better. There we go. Right here is pushing into, I mean, this kid's chest wall goes like this, right? Right at his heart. And I'm assuming it's a boy. And pushing right into that ventricle, and it doesn't matter if you're in systole or diastole, it's the same. So you don't get any break here. Now I push the, did this make it not go forward? There we go. Sorry. So PFTs, we know that after we fix the bars, multiple studies, that your PFTs improve, your FEV1 can improve. We think about this more as a cardiac compression issue than as a pulmonary issue, but we have seen some improvement in your FEV1 after we take your bars out. So bars in, bars out after treatment. And the CPET for the pediatric patients, the VO2 max does increase. So fixing this, repairing it, taking your sternum off of your heart does improve your exercise tolerance. Oh, new quiz. All right, what's the ideal age to evaluate and repair a patient with pectus excavatum? 5 months old, get them before they even know that they have a problem. 5 years old, do it before school. 12 years old, 18 years old before they launch. Oh, whoops, sorry guys. Can I go back? No? Here, we'll just watch it real time. I was like, the music didn't start. I have to push a button for the music. Nobody else can vote? Okay, all right. Sorry, that was my bad. I'm not used to this. And I'm a surgeon, like let's keep going. All right, so you're right, 12 years old is the right age. You know, in certain countries, they will do this at a very, very young age, and I'm talking about Asian countries. There are countries in which everybody's supposed to look exactly the same. They will repair them multiple times in their lives. If they recur, they don't talk about those numbers very much, but they'll do 2-year-olds, and it's a little bit frightening. 5-year-olds, probably not. They're not going to tell you they have exercise intolerance or any kind of issues. They're not going to complain as much, usually the 5-year-olds. 12 years old, early adolescence, that's really 12 to 15, I think, is the golden range to fix this. Their cartilages are still flexible enough. They understand what's going on. They can have assent, like they can say, yes, I want this done, or no, I don't want this done. And they're in their parents' purview, right? Like they have somebody to take care of them, which is what I love about pediatric surgery. You're not just taking care of an adult who may or may not follow your instructions. There are people there making sure the kids do this. So I love it. I love it. We've got partners in care for kids. So yes, 12 years old. All right. And then here we go into adult VO2. So adults also, if they don't get fixed as kids, then they're in the adult category. And the adults are harder to fix. And my friends who do this as an adult, they have more issues, more difficulties. They've had to modify the procedures more because adults just don't lift as much. And they have other pathology too that goes along with just having pectus. But they also show significant improvement in their VO2. So even if you don't get this as a kid, when you're an adult and if you're having troubles, it can still be fixed and it can still improve your VO2 and your exercise tolerance. Another thing that's really important is your body image and physical activity when you have pectus. So this is a nice multi-center study that looked at pre-op and post-op patients. They used this Pectus excavatum evaluation questionnaire that was vetted and evaluated, and it was modified for adults, but this is for kids. They looked at The patients, they asked for their body image and physical difficulty. Parents, they asked about emotional difficulties, social self-consciousness, and physical difficulty. And what they found is that the patients found that their body image improved significantly, their physical difficulty decreased significantly. The parents thought that their kids' emotional difficulty was less, their social self-consciousness was less, and their physical difficulty was less too. So they correlated, which is nice. And I guess the way that the questionnaire is set up, like social self-consciousness is not something that most kids are really super aware of, but parents know about that a little bit more. So definitely improves them. So what do we do about this? Now, this is the procedure that's changed significantly over the last, I would say, 50 years. We used to do a Ravitch procedure where we do a big open incision, take the cartilages off of the sternum, reshape, sometimes break the sternum, and then put a little strut underneath and hope that those cartilages healed the right way. We found out that that wasn't really the best operation to do. The cartilages don't always heal the right way. There's a high incidence of recurrence, and the chest doesn't necessarily heal in a symmetric way the way you want it. Donald Nuss in 1989 came up with a new, or 1998, sorry, came up with a new procedure called the Nuss procedure, and basically it was putting metal bars underneath of the sternum and lifting them up and securing them to the, or like stabilizing them on the chest wall. This has now become the standard procedure for a Nuss or for a Pectus, and over 100,000 of these cases have been done worldwide. Since his first description of this procedure, there have been probably about 100 to 150 modifications to make it safer and work better. We do sometimes still do a modified Ravitch where we do cut some of the cartilages, especially for that arcuatum, so where the sternum itself, that's a different thing altogether. The sternum in an arcuatum is bent. The sternums in both carinatum, where it sticks up, and excavatums that go down, they're kind of normal sternums. But an arcuatum sternum is foreshortened and it has a curve in it, like it is an angled thing. You can't just lift up the bottom part because it'll lift up the top part with bars. So you do have to cut that sternum, and sometimes there are cartilages that need to be modified too. So just little cuts, but then we plate and just, it's a big operation. They end up doing okay, but we also have to put Pectus bars in them to make sure that they lift all right. There's some carinotums that won't brace that we'll do a modified Ravitch on, and sometimes adults with Pectus, they just are too stiff to move, and there's a hybrid procedure that we do for that. So the key points of this operation, this is what makes the operation safe. Initially, a lot of these things weren't done. When Donald Nuss first did this, he would just stick a bar, a metal finder underneath of the sternum and just blindly go across, and then attach a bar that he shaped to the chest wall to the other side of that, and then flip that over. It sounds like it's okay. You can kind of feel your way across, but that's super scary. And now that we do a lot more thoracoscopy, like never ever should happen. But so things that we do differently. Before we start the operation, or before we start any kind of dissection, we'll elevate the sternum. There's a little tenaculum we'll use, I'll show you this, where we pinch the sternum up and lift it up. So when we do our dissection, it's straight across. We want to see everything the entire time we're in the chest, so have a camera in there always at an angle so you can see everything that's going on. We do a mediastinal dissection with a critical window. We want to make sure we see the other side, everything's clear. We don't use a ton of stabilizers. We do a lot of multi-point paracostal fixation, or we'll do some bridge plates, and we reinforce the intercostal spaces if you need to. Super important if it's an adult, there's just so much weight, or if it's a really big buff kid, oftentimes just the weight of their chest walls and the stress that's on the bars will push them down, and then you have a failed repair. Generally, we use more than one bar, and we want the entire sternum elevated. That picture of that kid who's on the cardiac MRI with that tip down, if you lift up the top, that the bottom of the sternum is still going to be pushing into that heart. So you need to make sure the whole thing is up. And then really importantly, over the last 5 years is cryotherapy, pain control. We want to make sure that this is, it's a painful procedure. It used to be horrible. Kids would stay in the hospital for 5 days. We do a lot of stuff to change that, lots of multimodal things. But now with cryotherapy, there's actually usually only one thing we need to do. So it's kind of cool. All right, so again, sternal elevation. It looks a little bit gruesome, but these are tiny little pokes. But basically, we put a tenaculum into the sternum and lift it up. And we've got this lovely thing. When we first did it, somebody had to actually hold it the whole time. And that, we needed to find a really tall, big resident to kind of do that lift for us. We're like, okay, you can relax now. Okay, lift up now. Really, really hard. I never wanted to be in that position. But now we have lots of things that help us move it up. And as you can see over on that side, side, we've got like camera ports and other things. In the middle, that's called a vacuum bell. A vacuum bell is something that the Germans invented 25 years ago. And what that does, it's a suction cup that you put in the middle of the chest, and then they pump it up, just like a manometer, like a blood pressure cuff, and then it sucks up this tissue. Works okay in really little kids and in Germany. And I don't know why it doesn't work here. I think it's compliance more than anything else. Like, you have to wear it for like 2 to 3 hours a day. It has to be consistent. Studies in the States have shown that like you can increase that. They just do measurements from the outside, and you increase the measurement on the outside by 1 centimeter if you're compliant with it. So it's not great. But people do use it. Some people ask for it. We do have it at Phoenix Children's. We show it to them. I've got 2 people to buy, and nobody's gotten fixed with it. So I'm not sure if it's, again, I think it's the way we are with families. This is just a different system. On the right-hand side, it's a Thompson retractor instead of a rule track, and you can use sternal wires. And this is actually from Holland, this picture. So they, different things all over the world, but everybody's kind of adapted this. You need to lift up before you go. All right, this is a picture. Is this our video? Do I go? Okay. So this is one of my partners, Dr. Bay, doing with our fellow, and they've attached the tenaculum, and they're looking with the camera. And this one. This is your pectus defect. This is the pericardium and the heart beating underneath of it. So you're gonna keep an eye on this and kind of what they do. All right, here we go. So Amer's attaching it, and then you just crank it up. And the chest wall lifts, and as the chest wall lifts, on the inside, you have space now. It's kind of glary, isn't it? But there's a lot of space there now, and now you're set for a really safe dissection. Chest wall looks better. You start to remodel the chest wall there. You're looking more straight across. You see those little bumps of the cartilages there? They're just the cartilages that were dipped down before, and now they're stretching. And when I'm doing this, I'm always like, okay, don't be greedy. The very first few cranks you do, you kind of wait a little bit, and then you do it a little bit more, especially on a big, stiff kid. But it definitely lifts up that chest wall nicely. So it works in several different ways. One is like safety, but then when you make your bars, you know kind of what your contour is going to be, and so you make your bars to that contour, and it's really nice. I love it. The other thing you have to watch for, and the cardiologist would look at this, is so you've got a lot of compression on your heart, and the reason we go slow is sometimes your blood pressure will drop when we lift up that sternum. So we wait for anesthesiology to catch up because they've had a lot of load on their heart, and suddenly we're releasing it all at once, and the kids respond. Not necessarily nicely. Okay, mediastinal dissection. So I didn't show you the entire video of the procedure, but this is a nice point. This is Dr. Notrika and Kristen, who's our PA, and they've already lifted up the sternum, and they've made that window underneath of the sternum and the pericardium here. You can see to the other side, and Kristen's over here with her finger on, the camera's on the right, she's on the left, and she's showing Dr. Notrika where the spaces that we have chosen to put bars are to make sure that the dissection is clean, it's fine. So really, really super safe. We want to know where we're going all the time with this. So here's an example of a kid with a really severe pectus. We can see his chest and kind of what it looks like on the outside there. And then that's when we're done. So nicely lifted sternum, everything straight across. He's got 2 bars. This kid has 38 millimeters between his sternum and his spine. And it's an MR, it's a different kind of picture, but on the right side, he now has 138 millimeters. So we lifted up this kid significantly. This is day 1 post-op. So lots of changes. It'd be nice to have an MR to an MR, laying down, but this is the best we do. This is upright. But a lot of room. That heart likes it better. Another example of a kid, pre-op, post-op. This is pre-bar removal on the right. He did really well. Actually, that was that kid. You can also do an asymmetric kid. So here's a kid who had a pectus excavatum, a pectus excavatum when she was older, but had a bad congenital diaphragmatic hernia actually on the right when she was a baby. Had a patch, went on ECMO. Now she's 14 years old, survived, and she got repaired with 3 bars and looks great. It feels better, had a little bit of an effusion after surgery, but definitely makes her quality of life improved. Different kinds of bars we use. This is an example of a titanium bar. Sometimes they're stabilizers that we use. Very rarely do we, though, in our practice, but other people do in different practices. What we usually do is multi-point fixation. You can do this with either titanium or stainless steel bars. So this is an example of a two-bar placement and a little bit more, this is a little extra because this is an adult surgeon, and they'll do, again, the hammock sutures are what are used to help reinforce those intercostal spaces in this area here. And so the bars can rest on those spaces as opposed to just relying on these ribs to hold them up in the shape of the bar. Some people will also drill holes through the sternum to hold up that bar. I don't think that's necessary in children, but sometimes in adults they'll do that. And then we make sure that we fasten these bars to more than one rib so they don't move. We don't leave the operating room until everything is really nice and secure. All right. Questions? All right, the length of stay and significant decreased need for narcotics post-op after the NUS procedure is due primarily to cryotherapy, physical therapy, pre-op methadone, pre-op gabapentin, or rib blocks with 0.25% Marcaine with epi. Good. All right, let's see. Yay! So cryotherapy has significantly changed our practice, and it is freezing the intercostal nerves at various places along the chest wall, and kids get a significant improvement in their pain control. And it works, I would say, 99.9% of the time. I just this week, though, had a redheaded kid, and he says he's not numb, and I don't understand it. So I'm trying to figure that one out. I froze him the same way I freeze everybody else, and he doesn't do it. I think physical therapy is very important. Pre-op methadone, we actually still use that a little bit. We used to use a full 10 milligrams, now it's 5 milligrams, and that's sort of part of the multimodal treatment that we use for anesthesia. We stopped using gabapentin altogether. It didn't seem to help a ton, and especially after cryo, don't really feel like we need it. We still do rib blocks. We still use local. It takes about 24 hours for the cryo to set up altogether, and so I feel like it's nice to give kids just a little bit extra for that. I'm not sure what this is. All right, so again, more bars. So this is a new system that came out just this past year. It's a titanium system that uses a bridge plate that can really significantly decrease movement of those bars. We don't actually have to do as many pericostal sutures when we use these kinds of plates. They're something that shows up on X-ray a little bit different, so I just want to make sure you guys saw that. So for cryoanalgesia, it ablates both the sensory and motor component of the intercostal nerve. People thought that, maybe you won't breathe as well. We've shown that actually the kids have normal PFTs both pre and post cryoanalgesia without any changes. And it only innervates the intercostal muscles. It turns out we don't use those a ton for breathing, and these kids do fine. We used to use thoracic epidurals, and actually not we, folks. Surgeons, anesthesiologists would use them. In some places they still do these. There was a really bad incident in Norfolk, actually, where they did tons of these before, and a kid ended up paralyzed, like for life, because of a thoracic epidural for the NUS procedure. So nobody really, or very few people do this anymore. And again, PCAs are used sometimes, not here. Elastomeric pain pumps were things that we used a lot before cryo, and I was like a big holdout on the elastomeric pain pump. I thought it worked great. I put it subpleurally, so intrathoracically, right along the nerves in the same place where we cryo. But pharmacy wouldn't let us send them home with kids, so we stopped using that and switched to cryo. We used to use gabapentin, again, don't anymore. So this is an example of us using cryo. Basically, there's a little probe. It goes into the chest. We deflate the lung and put that little probe on the intercostal space at the nerve. It takes 2 minutes to do it per nerve. We usually freeze about 4 to 5 nerves per side. So it takes a little bit of time, but it is definitely worthwhile because our length of stay has significantly decreased. So we looked at our numbers, and we had 350 NUS procedures done. We looked at the length of stay and opioid use, and we found that our length of stay significantly decreased. And we divided this into quarters because we were first using PCA, and we were telling kids they were going to stay in the hospital, 2 to 3 nights. So they would stay in the hospital 2 to 3 nights. And then as we started realizing that kids didn't really need to stay, they weren't really utilizing the medications that we could give in the hospital, the care that we could give in the hospital, they could do the same at home. We saw that the cryo was very effective. We did not see that they needed to be in the hospital. We did not have them come back to the hospital if we let them go on post-op day 1. And so the majority of the kids here on the yellow is quarter 4, 80% of the kids went home on post-op day 1. And now it's closer to 95% of the kids go home on post-op day 1. So a total change. They're out of school for far less time. Their need for opioids has significantly decreased. We're writing up a study now where we're looking at the number of opioids that we give and kind of how many they use post-op. And we found that our PA usually prescribes 10 pills of 5 milligrams of oxy to these kids, and the majority of people only use 5. So it's not, and then the question is disposal. So that's really what the study is about, but also looking at how many we really need to give. So completely different than when I started doing the NUS, where people would get 30 and then get refills. Certainly I feel like I contributed to the opioid crisis and feel horribly about that. And it's, you learn, but a lot of people were probably affected, and I think it's terrible. But when I started general surgery residency and somebody had a gallbladder taken out, I was like, well, what do I give them for post-op pain? And they were like, 30 of Vicodin. Okay, that's just what they got. But anyhow, hopefully that, we're changing that and things have gotten better, but really kids do well with this. This has kind of revolutionized the amount of pain and the timing that we do these operations. We used to only do them in the summertime or Christmas break, because then kids had more time to recover. Now we're doing these year long, certainly more in the summer, but also year long. Some people wonder about cryo and what happens long term. Back in the 80s, when thoracic surgeons were using cryotherapy, they had a different probe. It cooled to negative 180 or something. Now ours only cools to negative 60 with liquid nitrogen. And those people had long-term chronic pain. About 15% of patients who got that had long-term chronic pain. Granted, adult patients getting thoracotomies, so there's some confounders there too. But we wanted to know what happened sensory-wise. And we know that our kids who get NUSs sometimes are numb in the middle and on the sides, just where the pressure of the bar is and where we cut the skin on the sides, regardless. But with cryo, they're numb for the first 6 weeks, and then how do things get better? And so we looked at 47 patients that completed our study prospectively, and over 50% of those patients had complete sensation of their chest wall at 6 months. 40% had 2 dermatomes, so where the bars were still with sensory loss. So is it because of our pericostal sutures? Is it the bars? If we didn't have cryo, would they still be numb there? We didn't do the study before we started using cryo, so we don't really have a comparator, unfortunately. And then there's a certain amount who have neuropathic pain, or what we classify as neuropathic pain, but not like pain, more just numbness or tingling in the area that they say that they have pain, and it's different. Now, these kids actually didn't get any treatment for this. They didn't want any pain medicine, they didn't want gabapentin, they didn't want anything else. It was just a little annoying, but we still qualified that as neuropathic pain. So again, talking about length of stay, over 80% go home on post-op day 1. Again, that number is probably a little higher these days. And we have significant decrease in intra-op and post-op pain medications. PCA, we don't use anymore. Gabapentin, not anymore either. They get back to school sooner and back to activities sooner. So this is from last year, looking at 10 years, we had about 1,000 patients. The average Haller index, remember that depth, is 5.4, so 3.2 is significant, 5.4 is deeper. Our length of stay is now less. We've had a couple of infections, like any kind of operation we do. We did have to remove 1 bar and replace it because of an infection. Over the last year, there were no bar allergies. We previously had 4 allergies and 2 bar exchanges kind of overall for the last 10 years. We did have a 1% rate of bar movement. And that's something that, we don't like as surgeons. We want our bars to stay in place. 3 of these were revised because of a moderate shift causing pain, but that didn't change the chest contour. We could just see it on the x-ray. They complained of pain. We're like, okay, well, we can resecure the bars, put them back into position. Hopefully the pain gets better. Sometimes it's just adjusting the ends of them a little bit to make it less painful. There were 2 kids who really did have shift with partial recurrence, and those were replaced. And in 2023, there was only 1 of these. So I think as time goes on, we're getting better, but we're a really busy center and we see lots of kids. Plus, there was some question about after cryo, if you're so comfortable, are you going to go back to regular activity? And our activity restrictions are different per surgeon. And so I'm a little bit more conservative and I'm like, no contact sports for 2 months, take it easy, you can run, you can do other things if you feel like it, but let's just not play football or MMA or wrestling for 2 months at least after surgery. But I have other partners who will say, do whatever you want to as long as it doesn't hurt. So we'll see. Overall, we have had some recurrences after bar removal, and that's why we get a Baton score also. We look at kids for hypermobility syndromes. It's our hypermobile kids who are more likely to have recurrences after bar removal, or our younger kids. So we kind of have changed and revised what we do based on that. We do like to see them after surgery. I'll see them usually about 2 weeks after surgery and then generally 3 months. And then at intervals as needed, the bars stay generally for 3 years. Sometimes they go to physical therapy. There's some kids who don't want to lay flat. I feel like sleeping, we're made to lay flat. And if they're sitting up, it's like being on an airplane for hours and hours, going to India twice or something. And they end up with this funky little scoliosis. So I have them go to physical therapy to kind of just realign their back muscles. And then we see them again at 2.5 years before a bar removal visit. We get a 2-view chest x-ray, make sure if things are okay, helps us with post-op planning. And generally kids stay for 3 years. So questions about why we remove the bar at all. There's no evidence that says that we have to, right? But it is standard practice. We take them out. And the reason we do is because, well, it's a foreign body, it's left there. We don't want them to eventually end up with an allergic reaction, infection, or displacement. The bars, anything that's in your body can migrate over time. And certainly this is in your chest. It can erode into your internal mammary artery, your heart. Heaven forbid it shifts. And some of my adult partners who do this have had horrible Pectus cases done by folks who maybe don't follow the regular criteria to do this and have had issues with erosion. If you get hit on the side or if you've had an operation or had anything implanted and you get hit there, it hurts. So the bar can hurt over time. And then heaven forbid you need a sternotomy, and getting access to that, you've got these sternal bars in place, you're going to need to call somebody to take them out because the cardiac surgeons tend not to do this procedure. For bar removal, it's an outpatient operation. We unbend the bars and remove them. And the mantra is, if you place them safely, they get removed safely, and that is true. We usually have them 3 years in place. Marfan's kids, hypermobile kids, a little bit longer, Marfan's for sure, 4 years, hypermobile kids, 3.5 to 4 years. And this is how we decided on the right-hand side how long the bar should stay in. When Donald Nuss first did this procedure, he left them in for 6 months, and some of them did okay, but a lot of them recurred. And then, let's wait a year, same thing. And then he ended up talking to an orthodontist because his daughters were getting braces at that time. And it was like, why do you leave them in for 2 years? And he's like, well, that's about how long it takes for your teeth to kind of remodel and your bones to kind of reform in that area. And so he said, okay, well, let's try for 2 years now. And at 2 years, he got better results. And at 3 years, the results were just even better. And so our kids get their bars in, leave them in for 3 years. We just don't want to risk it. So pre-op, we get this 2-view chest x-ray. We plan this procedure as an outpatient. You want to make sure you do it in a place that has access to cardiac surgeons should you need them. You want to make sure in any of these procedures to not end up with a brachial plexus injury, so good positioning, and an assistant is always helpful. Recurrence is very low in older teens. Families always ask me about that. If you are less than 10 years of age, your incidence of recurrence is increased. This is a study out of Japan, and they were following kind of the Korean protocol for a while where they would do young kids. But then when they looked at it, they actually were scientifically more sound and reported their outcomes. And they found that is less than 10 years of age, just not a good time to do this. Again, we leave the bar in for longer if they have connective tissue disorder. And the number one reason for redo in adults is inadequate primary repair. So doing the operation correctly the first time is going to be key, and this is why I have these courses. I want people to do this operation right all over the country, and then here I think I talk about this in a minute, in October we have an international course here in Phoenix. So there definitely are folks around the world who are super interested in this, and there are definitely a lot of people who need this operation. We have a nice coordinator who makes sure to post stuff on social media about this, and the kids who say, hey, yeah, I do want to be seen, I do want to be posted, I want to show my pictures before and after. We have kids, a program where kids can talk to other kids who have had this done before. I can't tell you how many referrals I get from kids in the same class as another kid who's had this done. And they're like, don't you know Johnny? And I'm like, I'm not allowed to say that. I'm like, Johnny can tell you anything, but I just smile and nod. But really nice program. You need a lot of help. You need experience. We're trying to figure out a way to name centers of excellence, and one of the things is volume. You need to do a lot of these cases to get good at them. You need, obviously, surgeons involved, definitely our cardiologist friends, pulmonologist. Anesthesia needs to be comfortable with these cases. We do double lung ventilation. We switch back and forth. They need to be on board with us the whole time. Nurses that are trained in taking care of these patients pre-op, post-op, and in the operating room. And then physical therapists who understand the limitations of kids who have pectus bars in and what they can do and can't. We've got a big program. We double scrub these cases. We have hardly any infections compared to the national average, and we're constantly making changes as needed. If we find that something isn't exactly right, we keep learning. We keep talking to people around the world. We're leaders and help other people also improve their outcomes, improve their care, improve their safety. And you need to keep a database. We have a database of these kids to help us be on top of our numbers and make sure that what we're doing is actually good and adequate. Anyhow, coordinator's the key. Rebecca is our coordinator. She's your initial contact with the program for the patients. She makes sure everything happens. We're surgeons. We're everywhere at once. She gets everything together, answers questions. There's a dedicated number in an email. She works on marketing and outreach. She is the one who helps us keep the database and goes to meetings, learns new approaches with us together. So really, really important. And the kids want to give back too. This is a Pectus patient who made whistles because her house was so big that she couldn't post up. She couldn't call her mom adequately, and so she has whistles. So she gives whistles to Pectus kids afterwards. And I don't think everybody has that big house problem, but she did. Super darling. Super darling. All right. I'm open to any questions, and I'm just a tiny bit over time.
A lot of questions that come in the chat, and a lot of those you've answered at later parts of the presentation, but just real quickly, the pediatricians would like to know if you notice a pectus in a small kid, when should they get referred to you all? And what's the oldest, who's too old for this?
Yeah, so nobody's too old. We can see anybody in clinic. We can't operate past 26. We have to ask for exceptions, but we're happy to do an evaluation on anybody. The youngest that we like to see in clinic is about 10, 11, 12, with the caveat that we won't operate on them until they're 12, unless it's crazy severe and they're crazy symptomatic or they have something else. Now, the caveat to that, which is a little bit different, is the kids who have the arcuatum. Those kids you can see at birth. Sometimes the excavatum kids you don't actually notice until they're a little bit older when they start growing more. But the carinodums you can see pretty much birth 3, 4, 5. There is some thought that bracing could help these kids a little bit, so I don't mind seeing those kids young.